right. And our next speaker will be Dr. Richard Menger, who is Chief of Spine Surgery at South Alabama. And he's going to give us a talk on social economics of the spine. He's recently in Time magazine, I think 2 days ago, in an article where one of his patients' care got denied, and there is a great discussion. I encourage everyone to look it up.
Appreciate that. So thank you again for the opportunity. Really appreciate this. I'm going to step outside. I've heard some incredible clinical talks, and I'm going to kind of step outside that lane and kind of bring it back to just the reality of some of the world that we live in. So disclosures here, nothing relevant. These views are definitely my own. So there's always some sensitivity when you're talking about, right, money and socioeconomics, right? I think the reality is, like, we all love what we do, right? Or we wouldn't be sitting in a conference room in Hawaii, right? We'd all be outside doing something else, right? So there's a passion in what we do. And if you look at what Arthur Brooks sort of describes as like what you need to be happy, right? Enjoyment, satisfaction, and purpose. We're super blessed that we're able to, treat and bond with our patients and have a purpose-driven goal life. So that's not something to take for granted. And I think, just kind of making sure that's on the backdrop of what we do. And I, love the practice and support in South Alabama, taking care of children and adults and really being able to focus on deformity, right? But there are challenges as our health sort of infrastructure, changes, right? And there's a large amount of consolidation in our health networks and in our hospitals and in our care delivery, right? And it's sort of, with that comes the rise in the administrative sort of overstate of what we do, right? And I would make a very strong statement that this definitely impacts our ability to perform our job in a sustainable manner, right, to best serve our patients. So the focus is on the physician, but also being able to deliver care, right? So there are two slides that go in every presentation I do. This is one of them, right? This is a very real thing, right? And there's a lot of people that have seen this kind of morph over the years, but as rules and different things come through the healthcare space, that administrative burden is high, right? The money and the saliency of where the money goes is not to physicians, right? It's to administrator and other people who act in the space, right? So it's a real thing that we have to navigate. So when we attack these things or come up with a plan, right, we sort of understand the challenge, the dynamic of where we're at. Well, great. How do you make real gains for what you're going to do? How are you going to have a grand strategy that have tactical things that help do this, right? So, and that's my goal, to kind of have you leave here today with some real things that help sort of answer those questions, right? So I think the first thing is saying, being knowledgeable, know the data, be necessary in your sort of local environment. Right? We're all necessary to our patients, but I think it's a little bit deeper than that. And then know how to negotiate, right? So when people think of value, right, the number one thing that jumps to mind is like, well, how much money is this, right? And I don't think that's, again, entirely appropriate for what we do. So, what's the value to this patient, right, over the years of her progression, right? Her ability to kind of live and function, right? Same thing, right? Take someone from this to this, right? What's the value, right? Well, to the patient, that's very different than it is to the surgeon, which is very different than it is to the institution, which is very different than what it is to society, right? Those are really different, sometimes competing entities that we have to navigate, right? Same thing as a pediatric patient, right? You can see her contracture, her hyperlordosis, right? What does it mean for her to have her pelvic obliquity, treated, or her hyperlordosis sort of pulled out, as she hopefully compensates over time in thoracic plane? So, what does that value mean, right? And I think, again, it depends, of who your audience is and who you're talking to in the space that you're operating in, right? So however they define value is how they're going to make decisions, right? So if you look at the cadence of some, different administrators, right? Is that a quarterly balance sheet? Is that a yearly balance sheet, right? Is that different for Medicare, Medicaid, private insurance market, right? How you define who you're sort of marketing yourself to sort of matters, right? So the first step of this is know the data, right? So we heard incredible talk after incredible talk going through super unique data points about different measurements to go through and different things. And we would never show up to the operating room without some, similar mechanism of measuring the films, right? And coming up with a plan. We would never do that ever, right? So, the hospital's not looking at that. They're looking at this, right? So do you know the data for that? Because it's been a journey for me to try to unpack finding that out, right? So when we sort of enter discussions with other players, like, do we have the same data, right? So when I look at this and you look in your healthcare infrastructure, right, is you have to know the data, right? If you're in a work RVU contract, you need to know that. If you're in a collections contract, you need to know that, right? And you need to ask the sort of questions to your hospital and your health system about, hey, how am I, being a participant in this role and helping to push this forward? So I think, the knowledge part of this is difficult, right? And I think it requires, some nuances to it. But I think trying to put yourself in the shoes of the other person you're talking to, or the other person who has some stake in this, right? What is their knowledge and insight? What are they knowing and not understanding, right? Or what do you know that they need to know, or vice versa, right? And you have to understand the structure in your work, right? The value proposition for a minimally invasive spine surgeon operating out of an ASC, not attached to an academic system, cannot be any more different than a neurosurgeon at a level 1 trauma center, right? And I think we sort of intuitively understand that. There's a lot of different conversation points around that, right? So if you're a neurosurgeon, right, what's your value to your hospital? So like, that's sort of like data point one. Well, like, you can jump on Google and go through, Becker's and go through different things to kind of get some answers and say, hey, I'm a neurosurgeon, I'm worth $3 million to the hospital, right? So that's sort of the entry point for that. The USC group put out a very interesting paper very recently in the end of 2024, looking at this and saying, how much money is a neurosurgeon worth to a hospital system, right? So same thing, you want to know that information before you enter into a conversation sort of with your health system, right? So they're saying on average, neurosurgeon generates $2.6 million in revenue for the hospital. Okay, right? So that's your entry point data of sort of understanding your worth to the hospital, right? But I'll take it and keep pushing that one step further, right? So one of the questions and one of the things they always talk about, or it's very salient, is sort of your salary, right? So how are you going to negotiate that? How are you going to talk about that? How are you going to help build that forward? So again, it comes down to data, right? So the CNS worked with and collaborated with Resolve, right? And you can get access to this website for $200 and get access to it. I think it's somewhere in that space. And it gives you the exact data points you need to help negotiate your contract and understand what you're trying to do, right? So they have it by specialty. You can do it for orthopedic spine. You can do it for pediatric orthopedics. And it's going to give you the median compensation. It's going to give you the median work RVU, and it's going to give you what your work RVU target thresholds are, right? I would consider this is like the PILL mismatch, right? This is like basic entry level data you need to know before you sit down and negotiate your salary, right? So like, if you're in the 13,075th percentile for work RVUs and your compensation's in 25th percentile, now when you talk to somebody about that, you're having a very real conversation based on objective data provided to you by national corporation, right? So I think that's sort of step one. Well, you can keep pushing that and keep driving that, right? Nerves is an incredible resource for neurosurgeons, incredible resource where it goes through and really breaks apart through survey data. Hey, like, what's some data points for neurosurgery, right? So not enough just to say, well, the average neurosurgeon is this. Well, I'm in a hospital-owned physician group. I'm in a private practice group. I'm in an academic group. Look at the work RVU target difference between an academic neurosurgeon, right, and somebody working for a hospital, right? Again, you need to know that when you're sitting down and having those discussions, right? And you can look at all sorts of very interesting things in the starting salaries, but also for experienced hires, right? I think we kind of focus on the first contract, but what's that second contract sort of look like, right? Well, you can show that by year. You can show that by subspecialty, right? So again, arming yourself with the data so you can have those conversations, right? And in nerves, there's all different, sort of things you can go through, especially if you're at a more of a management level or helping to lead a division or a department in terms of how things are done so your peers can understand sort of what you're doing. And there's a lot that they kind of look at with that, where you can look at call compensation, you can look at how much support you get from your hospital, right? So all this can kind of, again, help you to give some discussion points. So one of the common things, or one of the things when you talk to your peers that you really hear about is, well, I want to have a nurse practitioner or a PA, right? Awesome. Well, here, Nerve shows you, like, well, this is the average compensation for a PA and a nurse practitioner, right? Many of us are in health systems, so that's sort of outside of our purview, but this is what the average compensation is going to be. Okay, right? And then you're going to turn around and say, well, how many work RVUs does a normal PA or nurse practitioner do, right? Well, here's that data, right? So instead of just saying, hey, I want to have a PA or hey, I want to have a nurse practitioner, you go in and you say, hey, look, I'm going to have a nurse practitioner. I'm going to have them see 8 new patients a week. 99204 is about 2.5 RVUs. So if we do that, this person will cover their cost in 1 year. Here's my proposal. What do you think? That's a very, very different discussion than like, I want a nurse practitioner with me, right? So I think that's the way we I kind of urge kind of tackling these things a little bit. And then, we took this one step further, and I sort of asked all of our peers, and we came up with this very intricate survey for young career spinal deformity surgeons. So 5, 6, 7, 8 years out of practice. Hey, what resources do you have? Are you burned out doing this? Are you successful with where you are? How many days a week do you operate? Who's with you in clinic, right? Real tangible things that probably impact our day-to-day life more than a lot of other things, right? So if you can turn around and say, hey, to go back to our APP example, 93% of my peers have some sort of advanced practitioner with them in clinic. I don't, hospital system, I'm trying to get us from here to there, help me with that, right? Then the other thing in the financial space, when we sort of look at this stuff, is we looked at, insurance and access to data and different things. And one thing that I found astonishing and definitely echoes true is that 80% of our young surgeon cohort do not have any access to any kind of revenue generation they're doing for the hospital, right? So we do certainly get a lot of cost-related concerns. We certainly get a lot of queries about making sure that we bill appropriately for MSDRG sort of elevation, but access to what we actually generate is low and somewhat cloaked, including people who said, hey, I'd really like to understand this so I can be a partner with you. And they're told no, right? So you could not quite fully understand that, but you can push that a little bit so you sort of understand. You can go through the MSDRGs, which is how the hospital gets paid from Medicare, are public information. You can get that information, right? And look at it for the type of surgery you're doing. Industry, and there's lots of different ones that have pulled these out for you as well too, right? So if you're in a meeting where somebody is trying to reduce costs in the OR, which is a valuable and important proposition, right? You also have to keep in mind, again, what your generation of potential income is in the margin on the case, right? So again, having information helps push this. I would sort of urge that and kind of iterate over and over again that this is not a transactional relationship, right? You really want to get out of a friction-heavy based, consistent negotiation every time you go somewhere, right, with your hospital or your health system. You want to say, hey, how can I help get you where you need to go, and you can help me get where I want to go? It's a partnership, right? The other parts of this is be necessary, right? So you want to illustrate and define value very broadly, right, in terms of what you bring to the health system and your role in that organization, right? The focus is on, we just talked about money and RVUs, right? It's salient. People think about it like collections, right? But it's much, much more than that, right? And I think, I'll give at least one economic theory discussion, right? You want to be inelastic in your demand, right, for you, right? So to put that into primitive economics sort of 101 discussion, right, is that like gum, your demand for that's going to be very elastic, right? If it's 99 cents at the checkout counter, you're going to get it. If it's $5,000, you're never going to get gum, right? So that's very elastic demand, right? Insulin, right? Well, if you're a diabetic, you need insulin no matter what, right? So if it's $500, right? Okay, if it's $5,000, that's frustrating, but I need it, right? That's why Farmer Bro got himself in such a bad, way of living. So when when you look at this stuff, you want to make yourself inelastic, right? So what that means is that you want to have as much value to your institution as possible. And that's different, right? We focus so much on cases and work overuse, but there's committees, right? There's citizenship. There's things that help make you a better citizen in your health system, right? And I think that all that, sort of works together to help us be stronger at our health system. All right. Sorry, it's not pushing forward here. Just sort of building on that, if this will kind of catch up for a second. So The next part of that, there's all different things. You can give a whole economic course about like demand and elasticity, right? But what that comes down to is you just want to be valuable to your health system in different ways. And that kind of looks different with different things you can do, right? And for neurosurgery, that's very, very sort of widespread, right? To have all these amazing things that truly transform your local community, right? You need a neurosurgeon, right? I would even make an argument your high-risk obese center from time to time needs a neurosurgeon, right? There's an aneurysm and the patient's in labor. What do we do, right? So these are very real things that, you, again, help sort of understand how valuable you are to your system, all right? And in the last 5 minutes here, I'll go over some very primitive stuff about negotiations and kind of living in a complex world that we have to. So this is a paper we wrote with the CSNS about, how to negotiate your contract, right? And same thing, right? We would never go to any kind of surgery, any sort of physical evaluation, any sort of discussion without understanding our basic tenets of anatomy. But we're going to show up from across the table from someone who's been negotiating with physicians or other people for 10 or 15 years, right? Without sort of having that sort of preparation. So I would sort of, again, push to make that part of our drive to help treat patients and thrive, right? So some of the terminology, right? And this is before you go into the negotiation, right? So you want to have a BATNA, right? A best alternative to negotiated agreement. So what am I going to do if I don't get what I expect or want in this negotiation, right? Reservation value is saying, hey, like this is as low as I'm willing to go, right? You have to be realistic and thoughtful about that, right? And again, use those other data points that we talked about to show that. And the zone of possible agreement is saying, hey, where, because the hospital is also going to have, or the health system or the insurer or the industry, whoever it may be, they're also going to have their reservation value. This is the lowest or the highest we can go, right? This is what we're going to do if this doesn't work out with you. So where can we find that agreement, right? Anchoring is a technique of, hey, who's going to put down, let's just use salary. Who's going to put down the first offer, right? And there's all sorts of debate about when you should do that or not do that. I think, you're going to look a little bit silly if you go into a giant health system and anchor your salary as a junior attending coming out, right? Well, that's very different than if you're going to go and say, hey, I'm going to build a research program and let me anchor with the resources needed to do that because you know that space better, right? And then that sort of sets the conversation around that. And I would strive, and we'll spend some time talking about value-based negotiations, which is everyone thinks of negotiations as a distributive sort of, I win, you lose, I'm going to get more value. That's not a really great long-term solution. So it's saying more, hey, how can we increase the size of the pot? Right. So I would, again, really urge avoiding high friction distributive negotiations of, I want $68 in RVU, not 64. Okay, fine, 66. And that's not the end goal. The end goal is saying, hey, how can we build a relationship to help us better take care of patients, right? And the way that you can do that in a way that is very helpful, has been proven in other sort of agencies, is you take down every single part of the negotiation, like what is there in a contract? What is and this is true for the highest level, the CEO of the hospital to the junior attending just starting, right? And saying, hey, these are all the different things, right? There's money, there's work RVUs, but then there's, going to conferences, there's having ancillary help, there's ownership opportunities, right? Then you sit down and have that, a 360-degree knowledge of saying, hey, what's important to me and my family, right? And what's important to my other partners, what's important to the university, right? And then you can come in and you can assign monetary values to these things, right? So if you're a person who's like, I love academics, I love teaching, right? I love going to conferences, right? I really, really dislike, doing cranial surgery. Okay, right? So how much is that worth to you, right? So you might find out very quickly that there's a high starting salary job at a hospital-based employment group, but it turns out if you're like, man, I can take, this call for you, I can take spine call for you, I can teach people. Oh, that's great because we don't have an education program and so on. So you find ways to increase the size of the pot and you assign basically a numerical value to things that are otherwise not numerical, right? And that'll help you sort of actually understand the magnitude of that author. And then the last minute is sort of like when you're in the negotiation, I would urge some sort of preparation for how you're going to handle that, right? In the same way, when you go into surgery, we all do some form of intensive visualization, right? I know if A doesn't happen, then I'm going to do B. And if B doesn't happen, I'm going to do C, right? And do we prepare for our discussions and negotiations that way, right? So labeling is a technique going through and saying, hey, I think you're saying this. Am I hearing you correctly? It's very clear, right? You're silent to allow for some appropriate responses. Mirroring is something where you sort of repeat back what they said, and it kind of generates a shared understanding. No-oriented questions is some very high behavioral economics data behind it. So instead of saying, do you agree? Is it, do you disagree? It's a lot more powerful, and it's a long discussion about that. And then the thing that I really like is an accusation audit, right? Like if you go in and you kind of get a sense of what's going on, instead of just sort of dancing around it, saying very clearly, hey, I can tell that you're concerned that if you give neurosurgery, a research position, orthopedics is going to also ask for that same research position. I understand that. Let me tell you how this is different, right? And you just sort of conquered the barrier that's maybe going to prevent you from getting what you need or want, right? So I think, again, last slide here. So definitely want to avoid being distributive, right? You want to increase the size of the pot, right? So, again, really appreciate the opportunity, right? We help people. We're really passionate about what we do. That's why we're here, right? We create a lot of value at every level, right? For our patients, for society, right? For our hospital systems and for us, right? So I think that understanding those data points and championing that in the same way we champion other patient causes is an important part of what we do. So appreciate it, and thank you.
Rich, it's a great talk. Just one question. I mean, I think being at the table and being able to have a say is great. As you mentioned, most of us are super busy with the OR and clinic and family. And how do you balance to find that time to be at the meetings, which oftentimes probably during clinic or during OR time? How do you actually make that work?
Yeah, so very difficult. So I think one is any meeting that you have some ability to do before surgery is what they do. So I mean, most of my meetings are very early, before the operating room. The second is that if for some of these other meetings or other things is that having someone who understands your sort of strategy and vision is bringing that forward, right? So like sort of decentralizing your command over everything that happens and saying, hey, our goal in this situation is develop a robust research infrastructure. Here's the widgets we need to be able to do that. I can't be at that meeting. When you go there, try to talk about these 3 or 4 things, right? Then that's sort of how you dodge that. But it's complex, right? And it comes at the cost of some other things, right? It's going to either come at the cost of being with your family or missing your research meeting or missing something else, right? So it's definitely a balance of how important that specific meeting may be. So.
I was going to just ask, you give the overview and the paradigm of the physician as the employee, and that's actually a relatively new shift, right? It used to be that the physician was the owner. How would this change again if we went back to that model? And what's preventing us from getting back to that model as physicians of owners of healthcare delivery rather than employees?
Yeah, appreciate it. Anthony's probably one of the greatest champions of physician ownership, coming back into the sphere. So I think, that shift is remarkable. You look at that, it's like under the age of 40, it's like 90% of physicians are going to be working for someone. And that creates every structure of, labor versus management that's ever happened, right? And this sort of dynamic is certainly there. So I think, very strongly, right, if you were sort of switch that to physician ownership, right, you're going to see buy-in that it's better aligned, right? I think there's no question about that, right? I think there's certainly, right, like if you're sort of framing it a little bit in the beginning, if you're doing MIS discectomy work and single level ACDFs and artificial disc replacements at an ASC, and you have some ownership in that, and now all of a sudden like you have complete control of your local environment, that's a very different dynamic than I'm going to do T4 to the pelvis of the PSO. Right, because you need those additional resources that the health system can provide, and navigating that appropriately. I think the better alignment in the data, even if physician-owned hospitals themselves, right? So yeah, great question, but I think definitely will change the dynamic. So.